Mission में है प्रशांत देसाई इंस्टाग्राम पे वीडियोस ऑफ मिलियंस में फॉलोअर है और के पास कोई डिग्री भी नहीं है कई वीडियो देख के पहचान के बड़े
So we'll be discussing about the various aspects of precocious puberty in boys using a lot of these case scenarios as well as the different aspects of evaluation and management in these regards, which becomes relevant from that perspective. So precocious puberty, as we were discussing, is something which is rarer in children as compared to the adult population, as compared to the female, in compared to the boys will have lesser chances of having precocious puberty, but once they have precocious puberty, there is a greater risk of developing a pathological cause in that regards, and that's something which is important to understand from that perspective. So we have this 5-year-old boy who presented with early puberty, and we can see clearly pubertal development was there, and there was a level of LH and FSH which were not elevated. So usually we expect this to be a central precocious puberty where you have a high level of LH and FSH. And when we found that the LH was low, the first possibility which we considered was obviously in line of an adrenal disorder, which was excluded based upon adrenal imaging as well as a normal level of 17-hydroxyprogesterone. What was striking was that the HCG level was high, and this turned out to be a HCG secreting tumor, and this really highlights the importance in that perspective of identifying a pathological cause, because this then turned out to be a CNS lesion, a germinoma in the brain which was producing HCG, causing precocious puberty from that perspective. So precocious puberty in boys is less common compared to girls, but still 1 in 100 theoretically will have precocious puberty. The problem is identification is not that easy, because parents will come to us immediately if they notice any breast development or vaginal discharge. In boys, these changes will not be very evident, and that's why it is often not detected at the right time. A significant proportion of them, approximately half of them, may have a pathological cause, which is there from that perspective. So it's rare, but more likely to be pathological as compared to girls, and more likely to have a peripheral etiology as compared to girls in that perspective. All of you can go to have a look at our website, learning.growthsociety.in, which has got a lot of informative resources as well as courses which are there in terms of pediatric endocrinology, including our fellowship course and the pediatric endocrinology for postgraduate course. We do have frequent activities in the form of journal clubs, in the form of discussion PG lecture series from that perspective. There are publications including our basic, advanced, and protocol book, and our mobile app, which provides guidance with regards to different aspects of pediatric endocrine disorders. So in this lecture series, we will be covering the pathophysiology, the etiology, and the assessment and management of precocious puberty in boys. And at the end, we will have very interesting Q&A session in which we'll try to cover whatever we have discussed early. So all of you be ready for that Q&A session towards the end in that perspective. So when we talk about the hypothalamic pituitary gonadal axis in boys, we know that there are three major organs: the hypothalamus, the pituitary, and the gonads. The GnRH produced via the hypothalamus, the gonadotropin releasing hormone, which is a decapeptide, which has got 10 peptides, acts on both LH and FSH. So it's a single hormone regulating both luteinizing and follicle stimulating hormone. And these hormones will then respectively act on the Sertoli and the Leydig cell to produce AMH and testosterone. So testosterone production indirectly is controlled via LH and GnRH. This axis is responsible for development of puberty. Under normal circumstances, puberty is suppressed using inhibitory signals coming from the higher centers, predominantly converging in the form of GABAergic neuron and MKRN3, while there are stimulatory factors like glutamate and kisspeptin which play a stimulatory role and allow the onset of puberty at the right time in that perspective. Now, this testosterone has to be converted via 5-alpha reductase 2 to dihydrotestosterone, which acts on the androgen receptor, as well as getting converted into estrogen, which is responsible for epiphyseal growth. So the testosterone basically is a pro-hormone. It can be converted to estrogen and act on the estrogen sensitive tissues like lipid and growth plate, or in terms of DHT, which will act on the androgen areas of the body. Now, the adrenal produces the DHEAs, which will then get converted into androgens, and it's responsible for increased production of testosterone. So in conditions where you have got a adrenal production or an extra testicular production of testosterone, the testicular size therefore will be small, and testicular size is a key clinical pointer in terms of evaluation, assessment, and management of precocious puberty. Now, as we've discussed, the LH is predominantly acting on the LHCG receptor on the Leydig cell to produce testosterone, while FSH is acting on the FSH receptor to stimulate the Sertoli cells to produce AMH. Now, the predominant cellular compartment in a prepubertal testis is largely the Sertoli cells, with small contribution from Leydig cells. And as puberty matures, the germ cells also become higher in number and size. So the size of testis is largely determined by FSH, while the testosterone production is really regulated by LH. So based upon differential expression of LH and FSH, we will have different clinical scenarios which may happen. So isolated LH excess or LH excess like states like the HCG producing tumor or testotoxicosis, you will have increased activity of the LHCG receptor, which is then going to act on the Leydig cell to produce more testosterone. You will have more Leydig cells, but since Leydig cells contribute to a small amount as far as testicular volume is concerned, the volume of the testes will not increase much. So you may have discrepancy in terms of the testicular size and the amount of testosterone which is being produced, and that may be the first clue of apparent excess of LH in that scenario. Now remember, girls do not develop precocious puberty if there is an isolated LH excess, because you need both LH as well as FSH to cause pubertal development in girls, while in boys only LH alone may be good enough from that perspective. Now, if we now look at in terms of the scenario in which your FSH action is more, typically in the setting of hypothyroidism, because TSH has a structural analogy as compared to the FSH receptor, it is then going to have a predominant effect on the Sertoli cells. So you will have large increase in the volume of the testis, but since there is no Leydig cells increased activity, you will not have higher testosterone. So you will have a discrepant scenario of large testis with no pubic hair. This is macroorchidism. This is analogous to the scenario of von Wieck-Grumbach syndrome in the setting of girls with prolonged hypothyroidism. This again we will not really label as precocious puberty from that perspective. So just to recapitulate what I was talking about, in the prepubertal testis, the most component is Sertoli, followed by germ cells and Leydig cells. As the child becomes pubertal, the Sertoli cells become more. The Leydig component will be around 10 to 15%. And if we talk about the adults, we have got a much bigger 50% and above will be germ cells. And again, Leydig cell will be small. So isolated LH excess will cause increase in Leydig cell, but the testicular volume increase will not be that much. While if you have both LH and FSH elevation in the setting of a central precocious puberty, you expect the testicular volume to go up from that perspective. Now, the hypothalamic pituitary gonadal axis does have a significant change across the various parts of the perinatal and the postnatal period. So, during the fetal period, the HPG axis is highly active. It then becomes very, very low towards the time of the term, and then there is a rapid rise again. And this is what we call as mini puberty. This mini puberty can last from around 6 months to 1 year. It tends to last longer in girls as compared to boys. So these are changes which we have to be wary about when we are doing those sort of evaluation. Subsequent to mini puberty, we expect the hormonal levels to be on a very, very low level, and this quiescent activity will be there throughout that period, which we notice during the childhood. Then we will have increased LH surges at night, followed by continuous LH pulses which happen, and then you will have an increase in testosterone level. So this is the normal development in terms of the puberty. And the first change which you can notice is if you actually monitor the LH pulses, you will see a nighttime LH pulse to be more, but otherwise the detectable LH will be the first sign of development of precocious puberty in boy. And you can look at morning testosterone because this nighttime pulses are more, you will get an elevated morning testosterone which becomes important from that perspective. And finally, you will have persistent elevation of the LH from that regards. So within the setting of the hypothalamic pituitary gonadal axis, we can understand that precocious puberty can largely be central or gonadotropin dependent precocious puberty, in which you will have elevated levels of LH and FSH, and you will have a larger testicular size. The most important condition in this group will of course be the CNS tumor, CNS pathology, as well as the idiopathic form. On the other hand, if you have a production which is independent of the gonadotropin, we are talking about a peripheral form of precocious puberty, which is characterized by low levels of LH and FSH and a pre-pubertal testicular volume. And therefore, testicular volume is the most important thing to look at in a boy with precocious puberty. Central precocious puberty can be because of a tumor, radiation, trauma, or insult. The chances of idiopathic one is much lower as compared to girls, where 90% or more will have an idiopathic form from that regards. The most common cause of peripheral precocious puberty is congenital adrenal hyperplasia, rarely adrenal tumor. And as we'll discuss subsequently, CAH is something which will present mostly with either a simple virilizing form or a 11-hydroxylase deficiency, in which you will have much severe virilization in that regards. McCune-Albright syndrome can have activating mutation of the GTPase, resulting in increased GNAS1 activity, resulting in precocious puberty, cafe au lait spots, skeletal abnormalities, along with thyrotoxicosis, Cushing syndrome, growth hormone excess as other manifestations. And isolated LHCG receptor hyperactivity will also result in a scenario of testotoxicosis. If there is exogenous testosterone, which may happen because of the application of gels which have been given, you may also have a peripheral precocious puberty. Hypothyroidism theoretically is not really a form of precocious puberty. It's basically a cause of macroorchidism in that regards. One may rarely have testicular tumors which can produce testosterone, and here you will have unilateral enlargement of testes in that regards. So now I'll invite Dr. Alappan to talk about the etiology of precocious puberty, and we'll discuss then subsequently about the management from there. So over to you, Alappan.
Thank you, sir. So we'll start that we all know that the precocious puberty in boys is less common, but it is much more pathological in comparison to the girls. So we'll start with the etiology of the precocious puberty, which can be divided into two parts. Number one is the central part, which is the 50% of the chunk is presented as a central precocious puberty, where we have a high LH and FSH level, as well as increase in the testicular volume. Among the central precocious puberty, the most commons are the idiopathics. Though less in comparison with girls, where there is 90 to 95% of central idiopathic precocious puberty. Here, the percentage is around 30%. One shouldn't miss the organic or the neurogenic causes of precocious puberty, which is contributes around 20%. Among them, the most common are the CNS lesions or the tumors. That includes the hematoma, glioma, hydrocephalus, or arachnoid cyst. Some genetic or rare causes of genetic forms like MKRN3 defect or DLK defect may present with familial precocious puberty in that scenario. And one should ask about the insults that has been happened to the children in form of radiation, any infection to the brain, or any trauma to the head. Comparison to the central precocious puberty, boys have much more incidence of peripheral precocious puberty, around 50% both, and the most common causes in them are adrenal pathologies and some testicular pathologies. In adrenal pathologies and overall, the most common cause of peripheral precocious puberty is 21 hydroxylase deficiency, the congenital adrenal hyperplasia, contributing around 40% of cases. Other differentials in that scenario, like 11 hydroxylase deficiency, where there is hypertension associated with congenital adrenal hyperplasia, and adrenal carcinomas are present. In the testicular form, there could be the presence of testicular tumor, any HCG producing tumor, or testotoxicosis that can contribute precocious puberty in boys. Now we'll go one by one. First, the hypothalamic hamartoma. Hypothalamic hamartoma is not a tumor in the truest sense. Basically, this is a abnormal migration of subnormal tissue in the abnormal place, or we can say a congenital malformation it is. This hypothalamic hamartoma causes precocious puberty, and there are different thoughts about this precocious puberty, how it causes precocious puberty. Some says that hypothalamic hamartoma increases the GnRH pulses, which can cause precocious puberty. Some says there is increased production of TGF alpha-like growth factors, which can contribute to that. But the most acceptable theory regarding this is it inhibits the inhibitory signals on the gonadotropins, leading to increase in the gonadotropin secretion. In this setting, the hypothalamic hamartoma is usually seen at the base of the third ventricle or the tuber cinerum, and it is usually a pedunculated mass. If we go for the biochemical pictures in the hypothalamic hamartoma, we can see there is a high levels of LH, FSH level, but disproportionate to the high LH and FSH level, the testicular volume doesn't increase too much, because the presentation of the hypothalamic hamartoma is much earlier, around 1 to 2 years of age, and there is less time to develop this testicular size to increase in the greater than 6 ml or more than that. So there is a rapid progression, and already discussed, as these things are associated with tuber cinerum and a pedunculated mass. There is no role of surgery in case of hypothalamic hamartoma, and high dose GnRH analog is the treatment of choice in case of hypothalamic hamartoma. This hypothalamic hamartoma is usually sporadic, but there are some associations usually that can be seen, especially in Pallister-Hall syndrome, where there is a defect in the GLI3 gene that can be seen. The next is the neurofibromatosis 1. Neurofibromatosis 1, as we all know, it is an autosomal dominant condition in the chromosome 17q11.2 and causing defect in the NF1 gene. This neurofibromatosis 1 can present with various manifestations like café-au-lait spot, Lesch nodule, and axillary freckling. This café-au-lait spot is usually a regular margin, and it can present anywhere smaller in size. But in the setting of neurofibromatosis 1, if precocious puberty is developing, one must not miss the possibility of glioma that is usually present in the optic nerve. This glioma, as it can cause central or GnRH dependent precocious puberty, also can secrete excess GS, leading to GS excess like state. The causes of precocious puberty in neurofibromatosis 1 is not only the optic nerve glioma, but sometimes there are other pathologies like hamartomas can be present, or some tumors causing the compression in the brain that may lead to precocious puberty in this child. The next is the HCG tumor. As you all know, this HCG producing tumors can cause central precocious puberty in the boys as well as peripheral precocious puberty. The most important central precocious puberty in this child due to the intracranial HCG producing tumor or germinoma. These germinomas can be present in the two regions, in the pineal region as well as in the stalk. They are present in a synchronous manner, but to cause precocious puberty, pineal germinoma or HCG producing tumor are much more important. They have a much more compressive effect leading to CNS features, and HCG tumor, as it is a HCG tumor, it has a LH effect that can be seen. The diagnosis of this HCG tumor can be done by using a CSF level where there is a high HCG level. These tumors are very radiosensitive, and radiotherapy is the treatment of choice in case of HCG tumor. Now coming to the some malformations that also can cause precocious puberty in boys, like hydrocephalus, arachnoid cyst, and some cerebral dysgenesis. The hydrocephalus is very important because it is one of the most reversible causes of precocious puberty in children. That means if we treat this child, the chances of reversal of precocious puberty is high there. It is usually early onset, but it is a reversible one. Arachnoid cyst is nothing but it is a fluid filled or CSF filled cyst that is present in the arachnoid space, with causing the raised ICT. In both the scenario, in hydrocephalus as well as arachnoid cyst, it is the raised ICT which is compressing the brain and causing the disinhibition of the inhibitory signals on the GnRH neurons, leading to precocious puberty. The presentation of the arachnoid cyst is usually a late one. Another important thing is cerebral dysgenesis, commonly seen in case of girls, where there is an intellectual delay and increased seizure frequency. The cause of this dysgenesis is due to hypoxia, usually present associated with hypoxic inducing encephalopathy, and presented with a seizure like catamenial seizures are present in these cases. Now coming into the some genetic causes of precocious puberty, this KIS1 is one of the important modulator of puberty in case of both boys and girls, and this kispeptin and its kispeptin receptors, these are located around arcuate nucleus, which is around the blood-brain barrier. So it can modulate the negative inhibitory effects of sex steroid on the HPG axis. Also, it can modulate the some emotional or environmental or some nutritional effect on the GnRH axis. This kispeptin receptor was initially discovered due to the GnRH in a GnRH deficient person, where there is an inactivating mutation of kispeptin 1. Subsequently, the activating mutation of kispeptin or kispeptin receptor can cause this central precocious puberty, or we can say GnRH dependent precocious puberty. This is an autosomal dominant condition, and there is an early infantile onset of precocious puberty that is seen with a rapid progression that is associated with it. Another important gene is MKRN gene, which is an important cause of familial precocious puberty. Around 30% of familial central precocious puberty is due to this MKRN3, with 3% gene, 3% idiopathic central precocious puberty are due to the MKRN3. MKRN3 or Macaroon ring finger protein 3 is usually located in the Prader-Willi region, the 15q11.2, and it usually helps in the RNA binding or ubiquitin ligase. Now, this is a maternal imprinting gene. That means if the paternal allele that has come from the father is inactivated, or there is any loss of function or mutation, it leads to the precocious puberty in the childhood, though it is not an early onset as compared to the kispeptin, and it is a relatively slower progression of precocious puberty that has been seen. The other manifestations of this MKRN3 is the esotropia, clinodactyly, and some dental defects can be associated with it. Now there are some radiation induced injury. So radiation has two implications on the brain. Number one, if radiation dose is a lower dose, that means the low dose radiation is present, that can present with early puberty. It inhibits and we define this low dose of radiation around 12 to 18 gray. Below 18 gray, we can say that it inhibits the inhibitory signals and causing this early puberty. But if we use a higher doses like 30 gray or much more than that, that can cause a suppression of puberty leading to a delayed puberty. So in the setting of a early puberty, one should always be in the setting of radiation. One should be always cautious about the concomitant GSD, because early puberty will cause the skeletal maturation to go ahead and the bone age will be progressed. But at the same time, the growth hormone deficiency will pull down the child and decreases his height. So when we start GnRH analog in this child, there is increased chances of growth failure or not increasing the growth velocity. So we must be cautious about that thing. If a child with early puberty is having growth failure, not gaining the height velocity well, so we should think always about the concomitant GSD in that setting. Now coming on to the secondary triggered puberty. In a case of peripheral precocious puberty in boys, it is not easily diagnostic in the earliest period, because like in the girls, where there is a delayed sexual disorder of the sexual differentiation, boys have a usual late presentation. And due to this late presentation, it can be presented in twice way. Due to this late presentation, there is an increased testosterone production and other androgen productions. This testosterone and other androgen production will advance the bone age of the children. That can cause the secondary triggered central precocious puberty. As well as, when we treat this case of long-standing precocious peripheral puberty, we use the hydrocortisone or other steroids. There is a suppression of the adrenal androgens or adrenal testosterones that is producing. So this suppression of these androgens in our body will stimulate the HPG axis, which can lead to central precocious puberty. So in both ways, in a long-standing precocious puberty without treatment or after starting of the treatment, can cause a secondary triggered central precocious puberty in that scenario. Now coming on to the peripheral causes of precocious puberty, and the most common are the adrenal causes. Adrenal produces some androgens, and the major androgen is the DHES in that scenario. In this case, there are production of the adrenal androgens, and due to this adrenal androgens, there is virilization or other kind of precocious manifestation. But there is no stimulation of the HPG axis. So the testicular volume in this scenario will be small. The gonadotropin levels will be undetectable. The most two important differential diagnosis in these cases are congenital adrenal hyperplasia, which will be a gradual presentation with presentation of presence of the pigmentation. Another one is the sinister one, the tumors. That should be a rapid presentation and presents with the hypertension. We'll come one by one regarding this. Now, this precocious puberty we have already discussed can also lead to secondary central precocious puberty in the boys. Now, 21-hydroxylase deficiency, we all know the most common causes of peripheral precocious puberty, as well as most common cause of CAH. It is due to the deficiency of 21-hydroxylase, leading to low level of mineralocorticoid, low level of glucocorticoid, but high level of androgen. Due to this, there is the peripheral precocious puberty, and it is of two types. One is the salt wasting variety, where there is a low mineralocorticoid is associated with it. And another is the simple virilizing variety, where there is mineralocorticoid levels are not so low. The diagnostic test of this 21-hydroxylase deficiency is 17-OHP progesterone, which is very high in this scenario. And the treatment, we all know that the management is using hydrocortisone and the fludrocortisone in terms of mineralocorticoid replacement. Second is the 11-hydroxylase deficiency, which is a hypertensive variant of CAH. Here there is deficiency of 11-hydroxylase deficiency. Due to this, here is mineralocorticoid levels will be high, the glucocorticoid levels will be low, and the androgen levels will be high. Due to this, there will be hypertension in this child, but in the initial neonatal phase, there is a aldosterone resistance like state. So initially it will present like a transient salt wasting followed by a hypertensive state. The diagnostic test is 11-DOC, which will be high in this case. 17-OHP level can be marginally high in case of 11-hydroxylase deficiency. The treatment options is hydrocortisone alone, and we have to monitor for the blood pressure, electrolyte, and DOC level in that scenario. Now, there are some HCG producing tumor which can causes peripheral precocious puberty. These HCG producing tumors are usually present in the, they can be present in the mediastinum, they can be present in the CNS, they can be present in the liver. This HCG we all know has a structural similarity with LH. This HCG will act on the LH receptor and causes the Leydig cell hyperplasia as well as production of the excess of the testosterone. And this testosterone will cause this precocious puberty. But as against the central precocious puberty, we all know Leydig cell contributes around 10 to 15% of the testicular volume. So here the testicular volume will be not that enlarged as we see in case of central precocious puberty. It will be around like 6 to 8 ml of testicular volume. And one must remember there is an association of Klinefelter syndrome with HCG producing tumor. So in a boy with Klinefelter syndrome, if there is a rapid onset of virilization or there is a rapid onset of gynecomastia, one should not miss to check for the any mediastinal HCG producing tumor in that scenario. They are very radiosensitive as we have already discussed, and the treatment modality is radiotherapy. The tumors that can cause this testicular HCG production are choriocarcinoma, germinoma, teratoma, and hepatoblastomas. Now coming to the testotoxicosis, which is also known as familial male-limited precocious puberty. Male-limited is because this LHCG receptor or LH receptor is only causing precocious puberty in males. It doesn't cause precocious puberty in female. So this testotoxicosis, there is a LHCG receptor activation. This is leading to again similar manifestation like HCG producing tumor with Leydig cell hyperplasia and excess testosterone production. As comparison to the HCG producing tumor, here also there is a testicular volume is in intermediate size of 6 to 8 centimeter, very early onset with severe progression. The treatment of choice here is anti-androgens like bicalutamide, as well as we have to give aromatase inhibitor like letrozole to prevent the further estrogenic effect on the males. Now coming to the hypothyroidism, as Saraj already described, this hypothyroidism is not a precocious puberty in the truest sense. As we all know, in hypothyroidism, there is a decreased level of T4, T3 leading to increased level of TSH. And we all know this TSH is a glycoprotein which has a structural similarity with FSH, LH, HCG. So this high level of TSH will act on the FSH receptor in the males and causing the Sertoli cell enlargement. So the presentation here is macroorchidism without any virilization will be present. There will be no puberty present. This is a similar condition that is also seen in case of girls in that is called also known as Van Wyk-Grumbach syndrome, where there is a breast development, no pubic hair, menstrual bleeding, as well as ovarian cysts are present. The treatment of choice in case of hypothyroidism is only thyroxine replacement that will resolve this issue. Now coming on to the McCune-Albright syndrome. McCune-Albright syndrome is a post-zygotic somatic mutation that is usually seen in the GANS gene. This gene is nothing but it is a gene that is controlling the alpha subunit of the GS stimulatory pathway. The LHCG, LH, FSH, TSH, growth hormone, ACTH, all the glycoprotein hormones, they are using this pathway to manifest their effects. So due to this LHCG excess effect, there will be intermediate size of testis. As it is a somatic defect, their presentations are variable and one can have a secondary triggered central precocious puberty in that scenario. If the GNS pathway is affecting the TSH pathway, then it will be thyrotoxicosis. In growth hormone, it will cause GH excess. If in ACTH pathway, it will cause Cushing syndrome. And in MSH or MSH pathway, it can cause hyperpigmentation or sometimes cafe alert spot can be seen. The other manifestation or the other hormones accessing this pathway is the FGF24, which can cause a phosphaturic effect leading to a low phosphate rickets, or cholestasis can be sometimes seen, or hypertrophic heart diseases are also associated with this syndrome. Now coming on to the adrenal tumor, it is one of the sinister pathologies of peripheral precocious puberty. One should not miss this adrenal tumor. It is an androgen secreting adrenal tumor which is very rapidly progressive and causing precocious puberty. So the investigation of choice in this case would be doing a CT scan, because the USG can sometimes miss this adrenal pathology, and that management of choice is surgery. Thank you, sir.
Thanks a lot, Alappan, for covering this topic very well. We'll now move forward with regards to the management part. First, about assessment. So there are three major questions which are there in terms of evaluation of precocious puberty. In boys, is it really precocious puberty? If it's precocious puberty, it's central versus peripheral. And finally, what's the cause? So the definition of precocious puberty is very, very clear. So before 9 years of age, if you have any pubarchy or testicular volume increase, this will be a criteria for precocious puberty. Remember that penile size generally is not considered a criteria for puberty. But of course, if there is a significant penile enlargement along with pubic hair enlargement, then you will have to consider that also in that regard. Other pointers could be a rapid increase in height, change in odor, and acne, which may also happen from that regards. Now, we have been talking a lot with regards to how testosterone levels increase and how the testicular volume increase. What we need to remember is that typically with a testicular volume of 1 to 3 ml, the body should have no level of testosterone. The testosterone level rises between 4 to 6, and by around 10, then only you will reach a level of approximately 100 to 200, and then subsequently you will have the mature level. So whenever you're looking at the testicular volume and testosterone level, you can correlate. If you have high testosterone with a testis less than 4 ml, you are typically dealing with a peripheral precocious puberty, quote unquote, CAH will be the most likely scenario. If on the other hand, TV is more than 10 ml, you are most likely dealing with a central pathology, while intermediate testis could be a HCG producing tumor, a testotoxicosis, or a secondary triggered precocious puberty in the setting of a long-standing CAH, which is there. Now, differentiating central and peripheral is vital because this is important from a therapeutic perspective as well. So the most important thing to look at in a boy with precocious puberty is the testicular volume. If your testicular volume is increased symmetrically, bilaterally, definitely above 10 ml, it's the central precocious puberty. If you have levels which are less than 2 to 3 ml, you're talking about peripheral precocious puberty because of an adrenal cause. If you have intermediate, as Alappan said, between 6 to 8 ml, it will be an apparent LH excess in the setting of testotoxicosis or in the setting of McCune-Albright syndrome and all the disorders in which you will have some enlargement. If there is a unilateral enlargement, we are dealing with a testicular tumor, and that's important from that perspective. Now, what levels of LH should we consider as a marker of precocious puberty? So traditionally, we were talking about LH levels which were more than 0.6 to identify a central pathology. But now with increased sensitivity of the assays, these cutoffs have been shifted to 0.3 and in fact 0.2. So the use of GNRS stimulation test has become less. If your LH is above 0.2 baseline, this is central. Less than 0.1 is peripheral. 0.1 to 0.2, you should do a GNRH analog test in that regard. So we are now shifting towards this 0.2 cutoff because now we have got better assays. Radio assays used to be less sensitive from that perspective, and that becomes important. And what about stimulated levels? So the stimulated levels are more than 5. We generally consider that to be a marker of a central precocity. So central precocity typically has a later onset with concordant development with pubertal testicular volume and a basal LH level being high. Peripheral has an earlier rapid discordant development in the sense the testicular volume is not increased and the basal LH is very low in that regards. Now, once we know which way, we can then go forward in terms of evaluation of the cause. The onset will give you a picture. If you have a very, very early onset, we are talking about hypothalamic hematoma or rarely McCune-Albright syndrome. Later onset typically indicates a form of a central precocious puberty. If there is a rapid and a discordant course, then this could be an adrenal tumor you have to be worried about, or a HCG producing tumor, that is something which you're worried about. If it's a slow orderly pattern, it's more likely to be a central precocious puberty. Neurological features, of course, gelastic epilepsy is absolutely important. So if you have an uncontrolled laughter-like spells, start thinking of a hypothalamic hematoma. If there is history of radiation, trauma, and infection, that can give you a clue of a CNS pathology. Always ask for androgen exposure in the terms of presence of testosterone gel in the house, because that could be something which can be surreptitiously involved. Look at the family history, particularly for the MKRN defects, and features of hypothyroidism should be assessed. Blood pressure examination is absolutely essential because that gives you a clue of 11-hydroxylase deficiency or adrenal tumor. Pigmentation may be a clue towards a simple virilizing form of CAH. And if you have cafe au lait spots, if they are of irregular margin, they will be more likely to be McCune-Albright syndrome, or if they have a regular margin, you can think of a neurofibromatosis as well, and then go ahead and look for neurological examination also in that regards. Now, investigation is the most important one, of course, is testosterone, which will give you a clue whether the puberty has really happened in that regards or not. If the testosterone level is more than 20, this clearly indicates that the child has entered puberty. The best time to do a testosterone is the morning time, because we are talking about nighttime pulses, and herein you will have elevation in the morning from that perspective. LH and FSH, of course, become important, and usually now basal levels are good enough to give you an idea. So if the basal LH is more than 0.3, or in fact 0.2 now by many of the studies, we can consider this to be central. Otherwise, you can give a GnRH injection in the form of triptorelin, 100 micrograms, or leuprolide 20 microgram per kg, and assess LH after 2 hours. If the levels are more than 5, then you are dealing with a central precocious puberty from that perspective, and then you will get. Now, once you diagnose central precocious puberty in a boy, every boy should have an MRI, as against girls, where it is indicated only if it is less than 6 years of age. While if you're thinking of a peripheral cause, think of adrenal etiology, as Alapan was saying, get a CT scan done, look at 17-hydroxyprogesterone, and then if it is normal, think of 11-DOC to identify 11-hydroxylase deficiency. And of course, bone age is a very, very vital investigation from that perspective. So peripheral precocious puberty, as we were discussing, CT is definitely indicated. Simple ultrasound may often miss it. Look at 17-OHP levels. For HCG tumors, you can do HCG levels, and if they are high, you have to really look for where this tumor is. So get a CT scan of the head, the chest, the mediastinum, and the abdomen to look at the various forms. If it's a testotoxicosis, you can do a genetic study to get the diagnosis. So now if we compare the various forms of precocious puberty, if it's early onset, you're mostly dealing with either a congenital form like CAH or a LHCG receptor tumor, or you can think of a central form. If the testis is prepubertal, then you are dealing more with either adrenal pathology, adrenal tumor, or a CAH, while intermediate testes are giving you an idea of HCG tumor, testotoxicosis or McCune-Albright syndrome. LH above the detectable range is more likely to be central, while it's undetectable in the peripheral form, and from there you can do workup in the form of MRI head, 17-OHP in CAH, testicular or adrenal CT in testicular tumor, screening investigations for HCG tumor, and genetic studies for McCune-Albright and testotoxicosis. So the most important investigation is LH. If it's more than 0.3 or 0.2, you are dealing with a central form. Get an MRI done. Start off with GnRH analog treatment, which we'll discuss subsequently. If it's below 0.1, it's peripheral. Get an adrenal imaging. If it's intermediate, you can do a GnRH stimulation test. In my experience, most cases of intermediate LH levels will turn towards the central cause, because theoretically, if your testo is high, your LH should be 0. This is how the normal response will work. If the GnRH stimulator is more than 5, this is central. Less than 5, this is going to be peripheral. In this case, you look at the adrenal mass. If it's there, you get the diagnosis. Otherwise, you go ahead with 17-OHP, which if it's high, suggests your CH, and then HCG, and then finally you can think of a LHCG receptor defect in that regards. So we have a 4-year-old boy with early puberty, and Dhwani, what we can see out here is that the testicular volume is significantly enlarged. In this case, now we have got a LH of 2.2, FSH of 3.2, and testosterone, which is high. What do you think is the most likely possibility in this young child?
Early onset central precocious puberty, you can have to go for neuroimaging. This can be a hematoma, look for signs of neurofibromatosis, which.
So this is a very significant pathology, and what we are seeing out here is that there is a normal tissue of the hypothalamus in an abnormal location, which means it's a hypothalamic hematoma, as you suggested. So this does not require any intervention. You have to give a GnRH analog in that regard. So early onset precocious puberty or central precocious puberty at any age in boys requires a MRI and imaging in that regard. 7-year-old boy with early puberty, testicular volume is 6 ml. There is stage 3 pubic here. Height is not that much advanced. Testosterone is high, it's 54 nanogram per DL. LH is 1.6, FSH is 2.2. What do you would like to do here, Dr. Alapan?
Levels are high in
Yeah.
central range. And also the testicular volume is also correlating with the
Yeah.
level. But in that boy child, so once you go for the any MRI,
So you should definitely look at imaging. And I think this is a big message, that don't get confused that if a boy has beyond 6 years, it will be normal. No, you have to look at the possibility. And what you can see here is that this is a arachnoid cyst. And many of these cystic lesions, as Alapan was talking about, the malformations basically disrupt the signaling pathway, and the inhibitory signals go off, and that's why you trigger precocious puberty. So this was the arachnoid cyst. Again, usually we'll give GnRH analog, wait for any symptoms if they are there, obstructive symptoms. Otherwise, you will just wait and watch in that regards. So 7-year-old boy with early puberty, the testicular volume here was small. So you have a large penis with a small testis. And you find this, that the adrenals are enlarged on the imaging. So what do you want to do, Dr. Sandeep, here?
This is large and the testes are puberty.
Yeah.
So definitely it's a precocious puberty, it's peripheral.
Yeah.
And in that scenario, we have a adrenal which is hyperplastic.
Yeah.
So most likely we are dealing with CAS.
So this is a very clear pointer. You have got peripheral precocious puberty with large adrenals. Your LH is low, testosterone is sky high. So as I said, if your testosterone is high, LH should be 0. 17-OHP is extremely elevated, and this would be a simple case of 21-hydroxylase deficiency. Now, once you start treatment, there will be a risk of developing peripheral precocious puberty. So what happens on started on hydrocodone, fludrocort? 6 months later, his testis, which was 1 ml, has become 4 ml. And bone age is progressing. So what do you think has happened?
So this case, due to hydrocortisone, there was a decrease in the production of testosterone.
Yes.
So it has activated the inhibitory pathway. It has taken off the inhibitory pathway, and then the central precocious puberty has started.
So this is something which Alapan has talked about. Now 17-OHP is normal, which indicates that your treatment is doing fine, but there is a triggered central precocious puberty. So in this case, clearly you have to think of GnRH analogs, and invariably, I think in all of our cases whom we have found of 21-hydroxylase simple verilizing presenting with precocious puberty, there will be a trigger, which is very common, because even if you pick up at 4 years, their bone age often is 11 years by that time. So you stop treatment, start treatment, suddenly the central trigger happens, and you have to be very, very wary about that in this perspective. 5-year-old boy with early puberty, you can see that the penile size is increased, the testicular volume is around 6 ml, it's intermediate. LH and FSH are not elevated. What do you think here?
Adrenal is normal, but we will still like to go for HCG levels and 17-OHP levels.
Yeah. So 17-OHP was normal and HCG was highly elevated. So this is a HCG producing tumor, and this is the case I was talking about. If you find HCG tumor, again, your work is not done. You have to go for localization. And this happened to be a germinoma, and they put in a shunt, and once they gave radiotherapy, there was a dramatic improvement in that perspective. So HCG producing tumor should be considered with peripheral precocious puberty with intermediate size testis in that regards. 6-year-old boy with recent pubic hair growth, he is not tall. You can see height is only 115. His SPL is significantly enlarged, 9 centimeters. Testis is prepubertal and bone age is not advanced. What do you think is happening here, Alapan?
6-year-old boy, hair growth is there. Testicular volume is first in the prepubertal range, and bone age and height is also not progressive. One thing that is striking is the SPL is 9 centimeter, but we don't consider SPL to be that much important in that. So we would like to see the gonadotropin levels in this scenario. And
so LH and FSH is low and testosterone is high. So this bone age of 6 years actually doesn't really reassure you. I will be more worried that he has such high testosterone and still the bone age has not progressed. It basically means it's all a recent onset thing. And parents give a history that suddenly he seems to have grown this. So do you think this is something sinister? Yeah, so 17 OHP, which is unlikely, was found to be normal. and CT adrenal showed a large adrenal carcinoma. Remember, whenever we talk about adrenal lesions causing virilization, they usually are carcinomas. So this is a bad prognosis scenario in that perspective. 3-year-old boy with early puberty, height is 106 centimeters, SPL is 9 centimeters, pubic hair is stage 3, and testis is 3 ml. So this is a very, very early onset. What do you think could be a likely possibility here?
Testis is not just reaching the puberty, sir.
Yeah.
So it is intermediate kind of testis. So we have to
Yes.
we have to look for the
So we cannot explain the stage 3 pubic hair or SPL of 9 centimeter with this testis of 3 ml. There is something unusual which is here. LHFSH is low, testo is sky high, very, very high, 120. CT abdomen is normal. Now, if you go by our workup, 17 OHP HCG is normal. So what do you think is left here? So either this could be theoretically macunal, right, which will be easy to identify, but more likely to be a LHCG defect. So that's why the receptor study will be there in that regards. Now coming on to the management, the treatment is based upon the condition. Of course, we can use a GnRH analog. So we all know that GnRH is going to stimulate LH and FSH. And if you have a very long-acting GnRH analog, that's going to desensitize the GnRH, and therefore the LH-FSH will go down from that perspective. For CAH, you can use hydrocortisone. For androgen receptor, you can block it using anti-androgen, as was discussed by Alapan. You can use aromatase inhibitors to really have more time in terms of bone growth. This is more towards testotoxicosis in terms of treatment. For HCG-producing tumor, you can do surgery or radiotherapy. Now, GnRH analog, basically, as we said, they stimulate LH and FSH. If you give a very, very high dose, you will have a decrease in terms of GnRH pulses. The LH FSH will go down and they will improve. You will have slower progression. There are various GnRH analogs available. They have been modified predominantly to allow a longer duration of action. Most of us use leuprolide. We start off with 3.75 monthly or 11.25 3-monthly. There's generally no need for giving a double dose here. In most cases, you will get control with that. If, however, the control is not good, you can then switch over to a higher dose from that perspective in that regards. Triptorelin is another good agent, and histoline is available basically as a once-yearly preparation in the US, but most of us use leuprolide, which is easily available. Now, GnRH analog preparation, as we discussed, leuprolide is the most common. Typical is 3.75 to 7.54 weekly or 11.25 12 weekly. Triptorelin, short and long preparations. Goserelin is another agent which is available in that scenario. Now, when you start on GnRH analog, you have to carefully monitor the child clinically for features of suppressed puberty, look at growth, and look at bone age effect. Now, as discussed, for girls, there will be no effect on pubarchy because already your pubarchy is there. It is not going to stop. And second, the adrenals are going to work continuously in that regards. Now, very importantly, with treatment, if you start treatment early, you expect a better response. Subsequent to that, the response is less. There's always going to be a flare in the initial phase. But if you do not give the dose at the right time, the suppression is lost and then again the flare may happen. So that is why giving it on the fixed day is very important to avoid this repeated flare, high and low effect. So the maximum gap should be a couple of days or maybe up to a week, but not beyond that in that perspective. You should basically look for and aim for a normal growth velocity, stable testicular volume. Pubic hair is not important. Bone age should be stable. On the other hand, if there is too much growth, if the bones are accelerating rapidly, your treatment is inadequate. We do not routinely do a GnRH stimulated LH levels, but if there are features of uncontrolled, you can look at that. And the target would be between 2 to 5 would be the suppression in that perspective. And then you can increase the frequency from that regards. If there is a dramatic growth suppression and the growth levels go below the physiological level to less than 4 centimeters per year, you can think of a concomitant growth hormone deficiency, especially if there is a radiation or a CNS tumor, and best would be to think of a GH testing and treatment from that regards. It's a very, very safe therapy. There are theoretical risk of bone density has not been documented. There's no long-term effect on fertility. And there is some weight gain which can be considered and countered using lifestyle measures. Remember, GnRH analogs are more effective in boys because they have a more severe disease as compared to girls. You expect more benefits in terms of oxology in boys. There are certain scenarios in which QT prolongation may happen. So you think of carefully in heart disease, family history, or sudden death in that regards. We generally try to treat the treatment by around 12 years of age, bone age of approximately 12 to 13 years, and when the predicted height is in the target range. So it's not just a single decision based upon your age. So how much is your height, how much is your bones, how much you want your height to be, and then you take a decision on that regards. So these are the recommendations which are available from the International Consortium, and they do talk about that for males, again they say the main issue is whether you should decide is based upon your skeletal maturation, which becomes important, and then you look more in terms of clinical parameters rather than going ahead with laboratory parameters, and bone age should be a very, very important to look at. One message which they give is that if your bone age is already above 14 years of age, there may not be too much benefit out there. But if you have a desperate scenario, you may consider after explaining all the details to the parents. What about CH? You can give hydrocortisone, which will suppress DHEAs. Testosterone levels will go down, but this will now result in the trigger of precocious puberty, and this then you will require a GnRH analog as we discussed. So closely monitor testicular volume, keep testosterone below 20, and consider GH. We have used GH in a couple of our patients who had very late presentation with peripheral precocious puberty, triggered central precocity. GH, GnRH analog, and hydrocortisone, all of them were given, and this has been shown to be effective in improving the outcome. And this is the study by Maria New group, which looked at growth hormone level in which there was improvement with the use of growth hormone and GnRH analogs to achieve a good outcome from that regards. Testotoxicosis or MAS are difficult conditions to treat. What you're trying to do is to control the end organ effect. So you want to cut down on the androgen action using anti-androgens like bicalutamide, and then you are using aromatase inhibitors to prolong growth because this will delay the epiphyseal fusion. So we have tried to cover the entirety. We'll see if there are any particular questions which are there, and then we'll have a quick Q&A session which are there. So at the moment, we don't have any questions. I'll request Dr. Alappan and Dhwani to look at the answers as people give. And we will be announcing the people who have the quickest answer from that regard. So this is going to be an interesting one, a recap of all that we've discussed. Dr. Sabina, please.
Thank you very much, sir. Sir has discussed in detail about the various about the etiology, the pathophysiology, and the treatment and the diagnosis. Now we are going to discuss about various case scenarios. So this is a 4-year, 2 months old boy presented with enlarged penis and testis. Testicular volume is 5 ml. SPL is around 8.5 centimeters. So the LS level is 2.2. So is it a central or a peripheral precocious puberty?
So you can all put it either in the Q&A or the chat. Are you able to see the Q&A in that? So anybody has put the answer? Okay, so you can put in the answer. So we have got one answer in Q&A. This is central from Dr. Vivek. So I think we agree with this one. Yeah.
Since the LH is more than 0.2, so it is a central precocious puberty.
Yeah. So this is right. So a lot of people are talking about central, which is fine. Dr. Aisha, Dr. Vedita, Dr. Tabassum Khatun, all of them are talking about. So this clearly the message from here.
The message is that whenever there is a precocious puberty, we have to go for the LS level. If the LS level is more than 0.2, it is central, and if it is less than 0.1, we are dealing with peripheral precocious puberty.
Okay. Yeah, carry on.
So the next case scenario is we have a 5-year-old boy. He is concerned about the enlarged penis. the testicular volume is 1 ml and the SPL is 9 centimeter. So the LH is 0.2. So since the LH is 0.2 and there is the testicular volume of 1 centimeter, that means we are dealing with a peripheral precocious puberty. And in this case, the CT abdomen was done, which showed diffuse adrenal hyperplasia, and the 17 OHP levels were 120, which is significantly high. So we are dealing with a case of 21 hydrolysis deficiency. So
Yes. So what are the pointers towards peripheral precocity is what we are looking at. So what are the pointers in this case which suggest that we have a peripheral precocious puberty? So what are the pointers that you saw here?
So in this patient, there was enlarged penis, but the testicular volume was prepubertal, first of all, which gives a hint towards peripheral precocious puberty. And again, the LS level was very low. It was less than 0.01. So it is a peripheral precocious puberty.
So Dr. Anju has clearly said LH level less than 0.1. Dr. Vivek has mentioned both LH and testicular volume. Dr. Ekta, I think testicular volume is something which is very, very characteristic in this regards. So that will be the clue for CAH as well. So yeah, carry on with this case.
This is a 3-year-old boy. He has increased penis and testis size. The SPL is 9 centimeter and TVF 4 centimeter.
So just hold on. So what do you think are the possibilities here? We have this case whose SPL is increased quite significantly and TV is only 4 ml. So maybe you can, people can put it on the chat box, the options which are there or the Q&A. Meanwhile, you can carry on with the case.
So in this case, the LH was 0.01. So definitely it is going to be a peripheral precocious puberty.
So there is a discrepancy that we are seeing here is that we have got SPL which is 9 centimeter and testicular volume is 4 ml. Dr. Anju is talking about hypothalamic hematoma. Yes, that is a possibility, as Alapan had mentioned, that because you don't have that much time for testes to grow, it may happen. Or germinoma also, HCG producing tumor, that's pretty much there. So 17 OHP here was normal and HCG was
HCG was 1200. So we are dealing with a HCG secreting tumor. And to locate the tumor, we have done imaging in which the CT head shows CNS germinoma. So the definitive treatment is radiotherapy.
Yeah. So I think that was clear. So we will now move to the next case.
6-year-old boy. He had a rapid pubic hair growth. SPL is 9 centimeter. Testicular volume bilateral is 1 ml and bone age is same as the chronological age.
So again, this is an interesting scenario of a rapid pubertal development, which is recent onset and normal bone age. So do you think this could be CAH? Maybe people can put up. TV is less, SPL is more. So this could be a peripheral and then this be CAH. Maybe you will then put on the Q&A. Or what's important from a bone age, chronological age perspective? What do you get out there?
So since the bone age is same as the chronological age, that means it is a very recent onset and there is no sufficient time has been given for the bones to grow. So definitely we are dealing with a rapid onset puberty, sir.
Yes. So we are getting clues. Dr. Aisha is talking about testosterone tumor, adrenal carcinoma, CH, unlikely. Dr. Anju, true. So this is very, very unlikely to be CH because otherwise the bone age should have been 11 or 12 by this time when they come to us. So this is definitely a peripheral precocity, as Dr. Vedita is talking about, most likely a tumor. So this is.
So we have to go for adrenal imaging. And the 17 OHP levels were normal, and the CT adrenal show there was a large adrenal carcinoma.
So again, a big message is that if you have rapid onset development, think tumor. So rapid development is unlikely to be because of something like a hematoma. That's usually very early. It will be rapid, but not somebody was normal at 6 years and suddenly you have a development happening. So it has to be a peripheral form, either a HCG producing tumor or this could be a adrenal tumor. Yeah, carry on.
So the patient was dealt with surgery followed by chemotherapy. 3-year-old boy concerned regarding the early puberty and slight increase in testis size. The SPL was 8 centimeter and testicular volume of 4 ml.
So how do you correlate? Because now I think the most important clinical clue is how much is your penile size and how much is testicular size. So what do you expect the testosterone level at this SPL?
Sir, for this SPL of 8, the testosterone must be around 100, sir.
Yes, so it won't be 20, 30, it has to be at least 100 because that's much growth has happened. So do you think this testicular volume of 4 can explain that?
No, sir. For testicular volume of 4, the testosterone has to be around 10 to 20, sir.
Yeah.
So-
So what are the options? So yes, Dr. Vedita has talked about testosterone more than 100, which makes sense. So this is something else again. So
Yes.
what do you think is the possibility?
So definitely we are not dealing with central precocious puberty. Then
Yeah.
we have to look for the peripheral precocious puberty. So we have done imaging. Adrenal imaging was normal, and LH, FHs were undetectable, obviously. 17 OHP levels and HCG levels were within normal limits.
So all the things are normal. So in this scenario, what is the possibility now in a very, very early onset child who doesn't have that much testicular enlargement? Maybe people can put it on the Q&A as well. So testotoxicosis, Dr. Anju is mentioning absolutely right. Hypothyroidism would be extremely unlikely because there you will have enlarged testis with no pubic hair growth and testosterone will not be high. You haven't mentioned testosterone levels, but it was very, very high.
Yes.
So this is a apparent LHX state and genetics will give you the diagnosis.
This patient was a case of LSAG receptor mutations, and he was managed with anti-androgens and anti-estrogen.
Yeah.
A 5-year-old boy presented with early puberty, SPL 8 and TV of 4.
So again, a similar sort of scenario as you were mentioning as a previous case. Now, Dr. Vivek has mentioned MAS in the last case. Now, you've given a clue here that there's multiple cafe or a spot. So this will obviously be a McCune-Albert syndrome in this scenario. Yeah.
And there was also bony changes in the X-rays. This is the clinical picture of the patient who had multiple cafe spots with irregular margins. So definitely we are dealing with a peripheral precocious puberty, and the case was of McCune-Albert syndrome.
So now whether this is NF1 or MAS. So what do you think? People can put it on the chat box. Of course, when it is because of NF1, you expect the testicular volume to be
higher, sir.
So this is going to be a central precocious puberty, and the type of cafe or spots are also more likely to be that of McCune-Albert rather than that. Yeah. Carry on.
So we are going to do some fact check. This is true and false. So the first question is: most boys with precocious puberty have some underlying cause.
So
Is it true or false?
So quickly you can write Y or N. Y for yes and N for you. So Dr. Vedita is saying true, Dr. Vivek, Dr. Anju, everybody is saying yes. True. Next question.
The second question is precocious puberty with enlarged testes suggests peripheral precocious puberty.
Yes. So I think this is the crux of whatever we talked till now. So Dr. Vivek is saying no. And I think we've got so many false. So this is the thing, the key message which is going out, and the most important thing is testicular volume, which is important. Yeah.
LH of 0.2 suggests central precocious puberty.
Yes. So I think this again, a lot of people are talking about yes. Dr. Aisha, Dr. Vedita, Dr. Vivek, Dr. Anju.
Recommend MRI brain in boys with CPP.
So do we want to do it for everybody with CPP in boys? I think this again is a very, very important message that we gave, that since the likelihood of pathology is more, we should go ahead and do an MRI in most cases. Yeah.
GnRH analogs are treatment of choice in central precocious puberty.
I think this again is a clear-cut message that we discussed in details in that regards. Yeah.
FSH is the better marker of pubertal onset.
So FSH is a better marker? No. So as we discussed, LH has a significant rise which happens. FSH does not rise that much in that perspective. Yeah.
Low dose radiation causes
precocious puberty. So this is something which is important. So if we give high dose radiation, we would have knockout of the complete pituitary. If you give around 18 gray or something, you will have precocious puberty. So Dr. Vivek has mentioned yes. Dr. Vedita also mentioned yes. So we are getting a lot of messages going on.
Hypothyroidism causes precocious puberty in boy.
So that's a controversial question. Now, what do you mean by precocious puberty? If you say testicular volume enlargement, then the answer is yes. If you talk about high testosterone or pubic hair growth, the answer will be no. So I would take mostly no as a correct answer, but yes, if you talk about testicular volume, so you will have a mirror image of 1Y-Grumbach syndrome in that regard. Yeah.
Suspect adrenal tumor in case of rapid development of puberty.
So yes, that's a very, very important message. So if you have anybody who was normal 6 months ago, has started precocious puberty, I'll be most worried about that case and get an imaging. If the LH-FSH is low, testosterone is high. So again, Dr. Anju, Dr. Aisha, Dr. Vivek talking yes in that regard. So carry on.
Consider testotoxicosis. If we have low levels of LH-FSH, we have normal adrenal imaging. We have normal 17 OHP, DOC,
So all
and
workup is
HCG.
normal. Do you think of testotoxicosis? Yes. So I think these 10 points that you have mentioned are clearly the key messages which were there. So the most important thing is to look at the testis, the LH levels, and then you decide about, do not stop at making central or peripheral. You have to reach the final diagnosis, get an MRI done. For adrenal, get a CT done. For HCG tumor, get a CT done of the head, the abdomen, and other aspects as well. So I think that was very good. So thank you.
Thank you very much.
Thanks a lot. So we will now be concluding the session. If there are any questions, we can take them. And all of you can go and have a look at our website for more information about courses, about books, as well as other aspects of tools which are there, and a mobile application which is there. So this was an interesting session, and we try to cover a lot about precocious puberty, a lot of interaction which happened. And we'll see if there are any questions other than the ones which are there in the chat box. So I think it was quite interesting, and we'll have the next session next month. I think we'll try to focus about delayed puberty in girls. So we are running through puberty. So we'll talk about delayed puberty in girls and boys, and micropenis, undescended testis, and then hyperandrogenism would be the way forward. Thanks, Dr. Alappan, Dr. Sandeep, and Dr. Dhwani.